Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 420 of our pharmacotherapy series, which discusses neoplastic disorders and their treatment, general principles.
The next case reads, SHP is a 57-year-old man who is currently undergoing a staging workup for a presumed diagnosis of metastatic adenocarcinoma of the lung. He has heard that cytotoxic chemotherapy is the only thing available to treat metastatic cancer. So my question to you reads, what other agents are being used to treat cancer besides those that are considered cytotoxic? We will first consider targeted therapy. By understanding the mechanisms by which cancer cells exhibit unregulated growth and immortality and possess the ability to invade tissues and metastasize, it has been possible to design drugs that inhibit these processes. Next we will consider monoclonal antibodies. Directed at specific receptors associated with cancer, monoclonal antibodies block ligands from binding to their targets. Unlike traditional chemotherapy, monoclonal antibodies selectively target receptors or their ligands known to potentiate cancer pathways, and as a result, minimize toxicity to non-cancer cells. And now let's consider tyrosine kinase inhibitors. Tyrosine kinase inhibitors, abbreviated as TKIs, are small molecules that directly inhibit tyrosine kinase activation by competing with ATP for binding to the intracellular tyrosine kinase domain. Advantages of these inhibitors include inhibiting cells that may not overexpress the receptor on their surface or have mutated forms of the receptor that result in its activation and direct inhibition of cell signaling. Even though most tyrosine kinase inhibitors are designed to inhibit a single target, they often have inhibitory properties for additional molecules, which could affect an internal cascade of biologic activity resulting in anti-tumor activity and toxicity. This class of drug is taken orally. Due to varying pharmacokinetics, specific instructions on self-administration should be provided to patients, i.e., take on an empty stomach, take with a full meal. Additionally, many tyrosine kinase inhibitors are substrates, inhibitors, and inducers of CYP450 enzymes. Attention to potential drug interaction is crucial to safe medication use. Provides the tyrosine kinase inhibitors currently approved by the U.S. Food and Drug Administration to treat malignancies. We will now look at other targeted therapy. Because more information is learned regarding signal transduction pathways and cellular growth and proliferation, more drugs are being developed that target these key molecules. Histone deacetylase inhibitors, mammalian target of rapamycin, mTOR, inhibitors, and proteasome inhibitors are examples of drugs that have novel mechanism or mechanisms of action. And now let's consider combination therapy with targeted agents. The optimal activity of adding targeted agents to cytotoxic chemotherapy is difficult to predict. Knowledge about how to combine targeted agents with chemotherapy is limited, although clinical investigations are ongoing. We will now progress to endocrine therapy. Endocrine therapy can be used to treat several common cancers, including breast, prostate, and endometrial cancers, which arise from hormone-sensitive tissues. These tumors grow in response to endogenous hormones that trigger growth signals. Current endocrine therapies inhibit tumor growth by blocking hormone receptors or by eliminating endogenous hormone feeding the tumor. Not all tumors arising from hormone-sensitive tissues respond to endocrine manipulation. Lack of response may be associated with hormone-resistant tumor cells or inadequate suppression of the endogenous feeding hormones. We will now discuss immunotherapy. Immune therapy is comprised of substances that stimulate the body's immune system to identify circulating tumor cells. Some agents target certain cells of the immune system. Other agents are more nonspecific. An individual's immune system plays a crucial role in developing or eradicating cancer. Normally, an intact immune system can protect the host against malignant cells and infectious pathogens, but current evidence shows that individuals with weakened immune systems are at an increased risk of developing cancer. Immunotherapy can include vaccines, cytokines, and checkpoint inhibitors. Sipuleucel T, marketed as Pro-Vange, is a cancer vaccine approved for patients with metastatic prostate cancer that is resistant to prior endocrine therapy. The immune system is stimulated to recognize the patient's own cancer cells. The cytokines, interferon alpha and interleukin-2, were the first immune-modulating therapies available. They nonspecifically stimulate B and T cell proliferation and differentiation along with activity on other immune functions. Immune checkpoint inhibitors release the brakes on the immune system, allowing it to identify and kill cancer cells better. If SHP is in fact diagnosed with stage 4 adenocarcinoma of the lung, he may receive other agents besides chemotherapy during the course of treatment for his disease. We will briefly discuss administration. Systemic chemotherapy is most commonly administered by the intravenous route, either as a bolus injection, generally for shorter than 15 minutes, short infusion, lasting 15 minutes to several hours, or as a continuous infusion, lasting 24 hours to several weeks. Some chemotherapy can also be administered orally, intramuscularly, or subcutaneously. Targeted agents are most commonly administered intravenously or orally. Monoclonal antibodies are primarily administered intravenously, whereas small molecule tyrosine kinase inhibitor are primarily administered by mouth. Endocrine agents are primarily administered orally or subcutaneously. Although chemotherapy was initially developed for systemic use, techniques have been developed to administer agents directly to specific sites of the body affected by the tumor. Regionally or locally administered chemotherapy allows for high concentrations of drug at the tumor site while reducing systemic exposure and subsequent toxicity. However, a potential disadvantage is that distant micrometastases may not be exposed to chemotherapy, allowing continued growth of tumor cells. The next case reads, PGK is a 67-year-old woman who was recently diagnosed with metastatic breast cancer. Her symptoms include widespread pain, anorexia, and fatigue. She has received 2 cycles of treatment with a combination chemotherapy regimen. A recent CT scan of her abdomen showed marked shrinkage at several tumor sites and her pain has decreased. So my question to you reads: how long should she continue to receive this chemotherapy? An important step in the treatment process is assessing response to treatment. This assessment should include evaluation of efficacy as well as toxicity, including impact on the patient's overall quality of life. Re-evaluation should occur at regularly scheduled intervals and include physical examination, laboratory tests, and repeat diagnostic imaging. Response evaluation criteria in solid tumors, abbreviated as RESIST, was introduced in 2000 to unify response assessment criteria, define how to choose evaluable tumors, and enable the use of new imaging technologies, such as spiral CT and MRI. The World Health Organization, National Cancer Institute, and European Organization for Research and Treatment of Cancer have adopted response evaluation criteria in solid tumors criteria as the standard for evaluating tumor response. Several standardized toxicity grading scales are available to assess toxicity associated with chemotherapy. However, the National Cancer Institute Common Toxicity Criteria for Adverse Events is the most commonly used. Because toxicities associated with systemic therapy are potentially severe, it is important to evaluate the risks and benefits. The benefits of a treatment regimen should outweigh the negative effects it has on the physical, mental, and social well-being of the patient. To monitor a patient's quality of life, several comprehensive assessment tools have been developed. In addition, other clinical benefits, e.g., reduced pain, decreased use of analgesics, weight gain, and improved performance status, have been recognized by the U.S. Food and Drug Administration as acceptable criteria for measuring quality of life. These criteria are also considered when evaluating new agents for approval. PGK should continue to receive the same therapy as long as her tumor is responding and she does not experience intolerable or life-threatening treatment-related toxicities. For some cancers, continued therapy after a certain number of cycles is not associated with further benefit, because toxicity becomes an overriding issue. Let's briefly look at tumor markers. Tumor markers are substances found in tumor tissue or released from tumor into the blood or other body fluids, e.g., urine. However, not all cancers have relevant tumor markers. The ideal tumor marker should be produced and released primarily by cancer cells, or by other tissues in response to tumor, at levels proportional to the tumor mass. Surgical removal of the tumor, radiation therapy, or therapeutic response to systemic therapy should result in a reduction in the level of the marker. In addition, the ideal tumor marker should be measurable at very low levels, allowing for detection of tumor at lower volumes than conventional diagnostic imaging permits. Tumor markers may therefore be used to monitor patients in remission and to detect recurrent disease. Unfortunately, few tumor markers fulfill these criteria sufficiently to be clinically useful as the sole screening or diagnostic test. Most tumor markers lack specificity for tumor and may be elevated due to other causes.
So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 421.